Good afternoon, everybody, and welcome to the third of our six-part series and Beyond the Numbers, the benefits of early and aggressive lowering of LDL cholesterol. Today, we are joined by Dr. Desai, and I will introduce him in a moment. But first, I would like to give you just a little bit of information about the three organizations who are sponsoring this series. We have Mended Hearts, whose mission is to inspire hope and improve the quality of life of heart patients and their families through ongoing peer-to-peer support, education, and advocacy. The National Lipid Association, or NLA, their mission is to enhance the practice of lipid management in clinical medicine, and the foundation of the NLA, and their mission is to improve the welfare of patients and families affected by cholesterol and triglyceride problems. So we are very excited to bring all three of our organizations together to bring you this great webinar series. As I had said earlier, today we are being joined by Dr. Desai. He is an associate professor of medicine at the Yale School of Medicine, associate chief section of cardiovascular medicine investigator at the Center for Outcomes Research and Evaluation. So we're very excited to have him with us today. All right, Dr. Desai, I'd like to turn it over to you.
All right, thanks very much, Andrea. I'm delighted to be with all of you today in this third session in this series, which I have heard has gone incredibly well, and I hope you have found it to be valuable, to be empowering, and I hope you find this one to be the same. So my hope over the next 35 or so minutes is to go beyond the numbers and to talk about two very related concepts, but I want to emphasize sort of two key points here. One is the benefits of early lowering of LDL cholesterol, and then the second is the benefits of aggressively lowering your LDL cholesterol. I know that you've heard in prior sessions about the importance of diet and lifestyle modification, and you've heard a little bit about statin therapy as well. And so I want to build on some of those prior sessions and take you through some of the numbers and really sort of try and connect some key concepts and actually bring the guidelines alive for you. I would encourage you to please submit questions through the chat option, and we'll try and get to as many of those as we can. And I'm very much looking forward to some back and forth. So with that, let's sort of kick it off. These are just some disclosures that I have. So the roadmap here, I think, is sort of threefold. So first and foremost, I want to talk about some of the science, some of the biology, frankly, of how LDL cholesterol causes blockages in blood vessels throughout the body, and how that then can cause, unfortunately, too often, and what we all want to avoid, heart attacks and strokes and other sort of events. Secondly, we'll talk about the importance of early management of cholesterol to prevent heart disease in the first place, and I hope that that's what we can do for the vast majority of people, is how do we sort of prevent problems from even happening in the first place. And then if someone has had heart trouble or a blockage in their artery or something, how do we sort of think about aggressively lowering their cholesterol to avoid any further events from happening downstream. And then finally, we'll kind of talk about some clinical research studies that have been done and the clinical guidelines that the professional societies, that the NLA, that American College of Cardiology, American Heart Association, amongst many others, have put forward that really represent our best understanding of cholesterol. And so those are sort of the three, I think, main points that we're going to walk through. So I want to start with this slide, and this is probably, may have been seen by some people. This is sort of a pictorial that, sort of takes us into a blood vessel wall over time. And you can sort of see that kind of time going from left to right on this picture. And what this slide is meant to highlight is just the central role of lipids, which are represented by that sort of yellow plaque. And what ends up happening over time is that cholesterol particles, and primarily LDL cholesterol particles, tend to build up in the blood vessel walls. That can build up in the arteries of the heart. It can build up in arteries that supply blood to the brain, maybe even arteries in other parts of your body. And then far too often, and I think what we're all trying to avoid, is what's shown on the right-hand portion of this figure, where that cholesterol sort of buildup in the blood vessel wall kind of tears open. And when it tears open, that's actually what causes a heart attack or a stroke or other symptoms in the lower extremities or in the legs. And that, of course, is what we're trying to avoid. And so what this, again, is meant to highlight is just how key a role cholesterol and lipids play in atherosclerosis, so blockages in the arteries, and in heart attacks and strokes and other things that we all want to avoid. So you might be sort of asking a question to say, hey, well, I've heard about all kinds of risk factors, right? I've heard about smoking and hypertension and diabetes, and I sort of wonder how important are lipids compared to all of those other risk factors that we've heard about. And so shown on this slide is sort of a summary of a very important research study that was done from actually around the globe. And what these researchers sought to answer was, what is the relative contribution of all of these different risk factors on developing a heart attack? And as you can see, all the way on the right-hand part of this screen, it turns out that when you look at all the data from around the world, that lipids are the #1 modifiable risk factor for blockages in arteries, for atherosclerosis, for coronary heart disease. And again, as you sort of think about the last slide and then this slide, I really hope that the takeaway from just these two slides is, wow, cholesterol is really important, lipids are really important. I sort of now even understand how lipids cause blockages in different arteries. And the research would certainly suggest that they are a principal or primary risk factor that we should be thinking about. So on this slide, I think the important concept that I want you to take away from here is that when we talk about the effects of lipids on blockages and on creating kind of heart disease events, what we're really talking about is cumulative effect. So you almost have to think about how high is the cholesterol and over how many years are the blood vessel walls kind of exposed to that high level of cholesterol. And as you get to a certain threshold, and that's what's sort of shown on that horizontal line going forward, that's demarcated as the threshold for coronary heart disease, that's really the range at which people will start to have more significant blockages in their arteries, and all too often they may actually have a heart attack or a stroke or the need for bypass surgery or a stent procedure. I think many people on the phone may be familiar with a clinical condition that we refer to as familial hypercholesterolemia. That's a genetic mutation that predisposes those individuals for having very, very high levels of LDL cholesterol. And sure enough, those patients, because their LDL cholesterols are so high, and essentially from the time of birth, they can have heart attacks and strokes very, very early on in their lives. And so you can sort of see that on this figure. Now, I think that what we want to spend our time thinking about now for the rest of the talk is, how do we prevent problems from happening in the first place? And I think what you should have taken away from the last couple slides is we need to probably lower the LDL and probably start, early if we want to talk about preventing adverse events. So for those of you that are on the phone and sort of asking the question of, well, gee, how do I prevent heart disease from happening in the first place. And should I take a statin? Should I not take a statin? You know, I'm hearing all these different things from, you know, maybe it's from your family members or from your neighbor or things you're reading. I want to take the next few slides to kind of try and demystify some of that. And I think the best way to do it is to think about what your risk of an adverse event is, of, you know, having a heart attack or a stroke or needing a stent procedure or bypass surgery. And a key tool that I would encourage you to use is a risk equation and a risk tool that's been put forward by the American College of Cardiology, the American Heart Association, and a number of other professional societies. And what's been done here is you go onto this website and you put in a number of parameters. And you can see some of those that are on the slide here: your age, your sex, your race, what your blood pressure was, you know, when you went to the doctor's office last, what your last cholesterol levels were, do you have diabetes, are you a smoker, you know, et cetera, et cetera. And after you input all of these different answers to these questions, the equation will then estimate, and you can see that at the very, very top. So in this sort of hypothetical example, the risk of a 10-year atherosclerotic event, so a heart attack or a stroke or another bad event, is about 8.3%. I think what's just as important is if you look on the row just below that to the right, where it says optimal ASCVD risk, that's what the risk would be if we got all the numbers and all of the variables optimized. So if we had people stop smoking, if we got their cholesterol in the right level, if we got their blood pressure in the right level. And so you can see that, you know, you can get a real sense for, hey, what is my risk? And if I make some changes and maybe I, you know, change some of these values, what my risk could actually decrease to. And I think this is a very empowering tool for all of you to kind of educate yourself and inform yourself around, you know, what your risk is and what you can do to try and mitigate that risk. Next slide. And then, and I know there's a lot of information here, and I just want to walk through a couple of key pieces of it. But again, if you're sort of asking, hey, I've never had heart problems before, I've never had heart trouble, and we all want to sort of keep it that way. You know, when should I start thinking about taking a statin? And I think that, you know, you probably have heard about some of this in prior presentations as well, but I want to point you first to the upper right-hand part of this slide, where you can see a number of kind of bubbles, if you will, that identify patients that should be taking a statin. So first, at the very, very top right, if you have an LDL cholesterol that's above 190 milligrams per deciliter, and that's after you've done, you know, kind of healthy lifestyle and diet modification and an exercise program, and, you know, you get your cholesterol checked and your LDL is still above 190, the best guidance that we can give is that you should start a statin medication. In fact, a high intensity statin medication. So that's kind of a certain statin at a certain dose. And we can talk more about that if you're interested. The second bubble is if you're a patient that has diabetes and your age between 40 and 75, that's sort of the second green bubble and the yellow bubble, you should at least be on a moderate intensity statin with the option of actually considering a high intensity statin. So there's enough evidence to suggest that if you're a patient that has diabetes and is aged between 40 and 75, and you've never had heart troubles before, you've never had a blockage in your artery, you've never had a stroke, you know, one of the best ways that you can actually prevent some of those things from happening is to start statin therapy. Next slide. And then the final kind of scenario to walk through, and this is probably applicable to most of the people on the call. If you're aged between 40 and 75, and the last time you got your cholesterol checked, the LDL was somewhere between 70 and 190. What I just walked through on the prior slide around the risk calculator, that tool, that's actually what we do in the office. So when I see a patient in the office and they sort of meet this criteria of age and LDL, and they ask me, hey, what do you think I can do to reduce my risk of having a bad event? I open up on my computer the risk calculator. I enter all the variables there. We get the answer for what the 10-year risk is. And based on which sort of bin they fall into, we sort of make a decision around, should we start a statin? Should we not start a statin? What are the different factors that might be at play for that? And again, just in terms of informing yourself and empowering yourself, I think this is a very important set of recommendations that actually represent our latest clinical guidelines on preventing cardiovascular disease. So I'm going to switch gears a little bit now, because we've kind of spent the first bulk of the slides kind of talking about prevention and trying to avoid things from happening in the first place. And we're going to talk a little bit about some different therapies now. And what this slide shows is about 25 years of clinical research. And what it's showing you is different LDL cholesterol levels on the bottom part of this slide. So you can see all the way at the right, 210, down to 190 and 170, kind of all the way down to 110, 90, and 70. And on the other axis, you can see rates of coronary heart disease events. So heart attacks, strokes, stent procedures, bypass surgery. And I think the key takeaway from this slide is it sure enough looks that if you have a lower LDL cholesterol level, that you likely have a lower risk of having one of those adverse events. And that should follow from everything we've talked about today, right? We know that LDL cholesterol and lipids play a central role in causing blockages and causing heart attacks and strokes. And so it would follow then naturally that the lower your level was, that the less your risk of having one of these bad things from happening. And sure enough, a lot of evidence would suggest that that is in fact true. And most of the research that is represented on this slide was done with statin type medications. And so we know that statins are the most effective, are highly effective risk reducing medications, and that lowering your LDL cholesterol with a statin will surely translate into reducing your risk of having a bad event occur. Just how much does it reduce your risk? Again, I've just tried to kind of summarize some of this for you. So if you look at patients across a number of years and a number of research studies, and just look at kind of the red highlighted box there, that patients who were receiving statins as compared to those who were not receiving a statin were about 21% less likely to have a bad event from happening. So again, as you're trying to just put some numbers in your head around, well, how much benefit do I get if I take a statin? This is what the best evidence that we have sort of available to us for that. I think where the field has been, and where all of us as kind of cardiologists and primary care doctors and people that take care of patients in the hospital or in the office have been kind of asking ourselves is, well, from all the evidence that we have, it looks like if you lower the LDL to about 70, that's a pretty good, that's where most of the evidence and most of the research has kind of led us to. And so the big question that we had kind of facing us was, what if you lowered the LDL even more? What if you brought the LDL from 70 down to 60 or 50 or 40, maybe even 30 or 20? And would that actually reduce your risk of having a bad event even more? And that has been actually the focus of a number of important research studies that I want to walk you through, and how that has actually informed our understanding and ultimately informed our guidelines for how we should take care of patients. So the first study I want to talk about is shown here. It's called the Improve It study. And what it did was it took about 18,000 patients that recently had a heart attack. And it gave half of them just statin therapy alone, shown here in the blue, simvastatin 40 milligrams. And the other half of the patients got simvastatin 40 milligrams in combination with ezetimibe 10 milligrams. And the investigators here essentially asked the question of, if you add Zetia or ezetimibe to a statin, does that actually improve outcomes for patients? So if we look on the next slide, I'll show you first what happened actually to the cholesterol levels, right? So shown here in the blue again are the patients that just got the statin therapy, in this case simvastatin. In the yellow are the patients that got the statin as well as ezetimibe. And you can see kind of in the middle part of the slide there where it says, you know, the average cholesterol was 69.5 in the statin group, or basically let's call it 70, and 53.7, let's call it 54, in the statin in combination with Zetia group. And so remember, we were sort of saying, well, one of the questions that we faced was, if you lower the LDL even further from 70, you know, down to 60 or 50, in this case 54, would that actually improve things for patients? And so let's see what actually happened in this clinical trial. So this slide then shows you the primary results of this study. So again, we've got the statin patients in the blue, we have the statin and the ezetimibe patients in the yellow, and sure enough, if you follow these patients over time, it looks like the patients that got both the statin and the Zetia did better. They had less adverse events, they had less heart attacks, less strokes, less need for stents and bypass surgery than the patients who just got a statin alone. And so I think IMPROVE-IT was an important study in that it showed us that even lowering the LDL from about 70 down to the mid 50s by adding ezetimibe could be a potential benefit for our patients. Now, I want you to remember that because, you know, towards the end of the talk, we're going to talk about some of the latest guidelines, and you'll see how even the guidelines sort of reflect on this data. So we're going to keep marching along, and I think we sort of went from 70 down to 54, and I hope many of you are asking, well, gee, okay, you showed us what happens if you go from 70 to 54. Well, what happens if you go from 54 to 44 or 34 or 24? And the truth of the matter is that for a long time, we never really had treatments available that could even get the LDL that low. And about 6 or so years ago, we got some new treatments available for cholesterol that for the first time actually enabled patients to get their LDL cholesterol down into that range. And you'll see some of that data on the subsequent slides. And those drugs are called PCSK9 inhibitors. And you may have heard of these, or been at talks or been talking to others about them. And this is just kind of a pictorial just showing you that these PCSK9 inhibitors, which are shown in the red on this figure, they actually work in the liver where a lot of cholesterol handling actually happens. And what they do is they enable the liver to soak up cholesterol particles from the bloodstream and essentially degrade them, put them in the garbage can. And therefore, the liver plays a very important role in actually managing your cholesterol levels. And the PCSK9 molecules then actually help the liver essentially do that in a much more rapid kind of way. So before we even talk about, what happened with some of the clinical research with the PCSK9 inhibitors, I want to show you one really important piece of data here, and that was from the GLAGOV trial. And what this trial did was it asked the question where they use a special ultrasound and they put that down into the heart arteries to actually look for the blockages and the cholesterol buildup, as I showed you kind of on that very, very first slide. And what they were sort of trying to sort out in this in this research protocol was, if we dramatically lower cholesterol with a PCSK9 inhibitor, what actually happens to the cholesterol plaque buildup in the heart arteries? And really the only way to look at that is with this special ultrasound device. And so that's what the investigators were sort of poised to do in this study. There were about 1,000 patients in this study. And again, I mainly just want to sort of emphasize to you how this worked, that everyone got this sort of special ultrasound at the beginning of their study so they could see, well, how much cholesterol buildup was there in the arteries. Then half of the patients got a statin alone. Another half of the patients got statin with the PCSK9 inhibitor, evolocumab, or known as Repatha. And then the investigators sort of did follow-up ultrasounds sometime down the road to see what happened to the cholesterol buildup in the arteries of these patients. So let's see what happened. So the first thing we have to look at is, well, what actually happened to the cholesterol levels? And so the blue line here basically shows you the patients that just got a statin. And in the orange, you can see the patients that got a statin with the PCSK9 inhibitor. And you can see that the patients that got the PCSK9 inhibitor, their cholesterol level, their LDL, went down to 36, versus the other patients that were just getting a statin that stayed at about 93. So it was about a 60% reduction in LDL cholesterol. I mean, these are numbers that we have essentially never seen before, because as I was alluding to, we basically never had treatments that could really lower the LDL this much. So on the next slide, you're going to see what happened by lowering the LDL that dramatically. What happened to what's called here atheroma volume? So what happened to all that cholesterol blockage buildup in the arteries? And when you see that sort of negative number, that negative 0.95 with the statin and the PCSK9 inhibitor, what that's telling you is that the plaque, the cholesterol buildup, actually decreased. Because when you lower the LDL that dramatically, you can actually cause blockages and lipid and cholesterol plaque to actually regress or reduce in size. I think that's a very, very compelling thing for all of us to be aware of, as you go back again to that very, very first slide about, what happens with cholesterol in the blood vessel wall and how that causes so many downstream problems, that now we sort of see that if you really lower the LDL, and in this case with the addition of a PCSK9 inhibitor, you can actually reverse that process. You can actually have the plaque go down in size, which is pretty remarkable, I think. And this is a very important slide, again, from the same study. And what it's showing you is what the patient's actual LDL was. And so you can see that on the bottom again, kind of from 110 to 100, 90, 80, all the way down to the 30 and the 20 range. And what actually happened, which patients actually reduced their plaque size, who actually had a reduction in their lipid plaque in their heart arteries. And sure enough, the patients that had the lowest LDLs, the people that achieved the lowest LDLs, actually had the largest reduction in plaque burden. So again, this is not really that surprising given everything we know about cholesterol and lipids and atherosclerosis and blockages in different arteries. But I think it's very powerful for you to see that if you lower your LDL, you can actually reverse some of the blockages that are in the different arteries. And so I think that's why I wanted to share GLAGOV with you, because you can actually see what happens to the plaque and sort of reversing the blockages that happen over time. And so with that, I want to sort of switch gears and just tell you about a couple things about, what have we learned about what the PCSK9 inhibitors do for reducing bad events for reducing heart attacks and strokes and the need for bypass surgery or stent procedures. And so there are two studies that I want to quickly kind of walk you through. And the first one is called the FOURIER trial. And this actually had over 27,000 patients from around the world. And all of these patients already had established cardiovascular disease, meaning that they already had a heart attack in the past, they had a stroke in the past, or they had blockages in their leg arteries that really affected their mobility. And the question here was, if all of these patients are already on a statin and half of them get placebo, and that's going to be shown in the blue, and half of them get a PCSK9 inhibitor, again, in this case, Repatha, what happens to future cardiovascular events? So can we prevent patients from having a second event, even if they've already had one, with the addition of a PCSK9 inhibitor? So per our usual, I'll show you what happened to the cholesterol levels first. So the patients that were just getting a statin and the placebo are shown in the blue. The statin with the PCSK9 inhibitor are in the red. And what you can see is the placebo patients had about an LDL of about 90. When you added the PCSK9 inhibitor, you lowered the LDL to about the 30 range. So again, if you rewind a couple slides and you think about, hey, we saw some data from going from 70 to 54 in Improve It. Now we're talking about going even lower, not to 44 or 40 or 35, but to 30. What actually happens? Is there still an additional benefit for patients? And that's sort of what's shown on the very next slide. So if you add the PCSK9 inhibitor and you drive the LDL down from 90 to about 30, sure enough, those patients actually have a reduced risk of having another heart attack or another stroke. And that's sort of what's shown on this slide. So it's a very nice, kind of way to connect the dots of, hey, you get an additional therapy with a PCSK9 inhibitor that dramatically reduces your cholesterol levels. And sure enough, it turns out that that actually reduces your risk for having another bad event from happening. I want to share with you sort of one other research study that's called ODYSSEY Outcomes. That's also with a PCSK9 inhibitor, alirocumab, or Praluent, as you may have seen in advertisements or in other conversations. And this study was similar in many respects to the FOURIER study, but a little different in the sense that they took patients that had a recent heart attack in this study. And so they took patients that had just had a heart attack, everybody was on a statin, and then they, again, half of the patients got a placebo, that's shown in the blue, and half of them got the PCSK9 inhibitor, in this case, the Praluent. So I'll show you kind of the same kind of data for this study. So first, what happened to the LDL? Well, the LDL was reduced from about 100 in the patients that were getting the statin and the placebo down to about 50 with the statin and the PCSK9 inhibitor. So again, a very large reduction in your LDL cholesterol. And then, of course, the natural question is, hey, we just want to make sure that this isn't just lowering LDL, but that it really also reduces the risk of another bad event from happening. And that's what's shown on the next slide. And so here, sure enough, very similar to what we saw with FOURIER, that you can, in fact, lower your risk of having another bad event with the addition of a PCSK9 inhibitor. So those patients who just recently had a heart attack, if they, in addition to their statin, if they got put on a PCSK9 inhibitor, they had a much lower chance of having another heart attack, a stroke, or having to be hospitalized for kind of a heart procedure if they got the PCSK9 inhibitor. Okay, so we've gone through a lot of slides and a lot of numbers and a lot of things, and so I want to just take a quick step back here and try and put some of this stuff together. And that's, kind of represented on this figure here. So what this shows is, again, these are data from FOURIER. So the investigators here took all the patients in the FOURIER trial based on whatever their cholesterol level was at week number 4 in the study. So some of the patients had an LDL of 100, they're represented in the blue. Some had an LDL somewhere between 70 and 99, they're in the orange. Some had an LDL between 50 and 69, they're in the green, and so on and so forth with the gray. And ultimately, the patients that are in yellow, they had an LDL of less than 20. So that, again, is a level that we've never, ever seen before, but we did see with some of the PCSK9 inhibitor patients because they can lower the LDL so dramatically. And so then they asked a very simple question. Sorry, just go back one slide. They asked a very simple question. They said, hey, well, across patients that have these differing LDL cholesterol levels, what happens to them if you kind of play forward and we can see, what happens to different people? And sure enough, the people that had the highest cholesterol level in the blue, they had the highest risk of having another heart attack or another stroke, and it was sequentially lower for each category of LDL. So the patients that had an LDL somewhere between 70 to 99 were sort of 10% lower than the blue. The green patients were 13% lower. The gray patients that had an LDL somewhere between 20 and 49 had a 25% lower chance. And those patients that had an LDL of less than 20, they actually had a 31% lower chance of having a heart attack or a stroke or another bad thing, as compared to those patients that had an LDL above 100. And so I think that, if we take a step back and say, what were some of the key questions that we wanted to answer? And one of those was, hey, we sort of had a good sense that, getting to an LDL of 70 was beneficial. And if the question was, well, if you lowered the LDL even further to 60 or 50 or 40 or 30 or maybe even 20, would that also translate or mean that those patients would have a lower risk of another bad event from happening? And it sure enough looks that way. And so this slide basically kind of summarizes almost 25 years of what's happened in our understanding of cholesterol. And believe it or not, in the early 1990s, people were wondering whether LDLs of 180 or 190 or 200 were bad and should be lowered. And over time, I think, again, what we've learned is that sure enough, as you lower your LDL from the 200s to the mid 100s to 100 to 70 and now even to the 20, 30, 40 range, that it really does seem to be quite beneficial for patients, that you can really meaningfully reduce your risk of having another heart attack or a stroke or another bad thing from happening if you aggressively lower your LDL cholesterol. For people that are interested in history, I think you will find this quite interesting. So this is a text of a speech by two individuals, Michael Brown and Joseph Goldstein, and they're very, very important in cardiology and lipidology because they're actually the ones who figured out how cholesterol is cleared from the body. And so, some of that work that I showed you from a couple slides ago about the liver and sort of what happens to cholesterol, they're actually the ones who figured all that stuff out. And they were recognized for the importance of their scientific work and their scientific contributions by getting the Nobel Prize. And so in 1985, when they were in Stockholm giving their speech, when they were accepting their prize, this is an excerpt from that speech. And so I've sort of underlined a couple of the key areas in red that they talked about. And they said a level of LDL cholesterol in plasma or in the blood of 25 milligrams per deciliter would be sufficient to nourish body cells with cholesterol. And then if you go down a little bit further, several lines of evidence suggest that plasma levels of LDL cholesterol in the range of 25 to 60 might indeed be physiologic for human beings. Now, with our Western diet and the way things have kind of happened, I think for too long, people just got comfortable with LDL cholesterols of 100 or 110 or 130 or 150. And sure enough, Brown and Goldstein, who I think know a thing or two about cholesterol, 35 years ago, were already telling us that, hey guys, it's probably closer to the range of 25 to 30 or 40 that might actually be the right level of cholesterol. And from what I've shown you over the last number of slides, it seems like it has taken us 25 years, but we're basically kind of getting to the same conclusion where they were many, many years ago, to their credit. And so kind of a final slide or two, just to kind of put all this stuff together and bring us home. And so what this slide is showing you is over time, you know, kind of starting in the 1980s, 1990s, all the way through to current day, what different specialty societies, what different professional societies from around the world. So there are some American professional societies that are represented here. There are some European societies that are you know, represented here, and what they have established as kind of an LDL target or a threshold. And you can see that we have continued to kind of be on a downward march for that, and that the most recent iteration of these guidelines are recommending somewhere between 50 and 70 for patients that have heart disease, in terms of, you know, what the most appropriate LDL cholesterol level might be, and we'll sort of talk about that again on the next slide. And so here we are. These are actually the most recent cholesterol guidelines that were put out by the American College of Cardiology, or the ACC, and the American Heart Association, as well as a number of other professional societies, including the NLA. And what it shows you, we're going to sort of focus on the right-hand portion of this figure where it says very high risk ASCVD, and we'll sort of talk about, you know, who that is. But the green bubble right below that says you should definitely be on a high intensity or the maximally tolerated statin. I know you've already had a talk on statins before, and I think very importantly that presentation talked about some of the adverse events or side effects that people can have and how we can best manage those. But it is very important that we start with statin therapy. And then in the yellow and the green kind of bubbles right below that or next to that, that you should consider adding a PCSK9 inhibitor and ezetimibe if the LDL cholesterol remains above 70. So if you have, quote, very high risk ASCVD, and we'll talk about that on the next slide, and you're already on a high intensity statin, and your LDL is still above 70, then it's probably good for you to engage with your healthcare provider around, hey, should we add ezetimibe? Should we maybe even add a PCSK9 inhibitor, because we want to lower that LDL even more, because as we've seen, there's certainly a benefit and you can reduce your risk of having another bad event from happening should you do that. So what is very high risk ASCVD? On the next slide, you'll sort of see the definition. If you've had a recent heart attack within the last year, again, we sort of at the very outset of this presentation said, you know, we want to prevent these things from happening in the first place. And that is absolutely our goal for everyone. But if, you know, you've already had a heart attack, or you've already had a stroke, or you have blockages in your leg arteries, then you are classified as being at very high risk. And so depending on what your LDL is and what medications you're on already, you know, you might sort of fit into that, into the guidelines that we were just talking about. In addition to that, if you have any of these risk factors on the next slide, including hypertension or diabetes, or you're a current smoker, you know, all of these things sort of add on additional risk. And so if you are a patient that has some of these high risk features, or you've had a heart attack or a stroke in the past, we want to be very aggressive about treating your cholesterol. If we can get there with statins, that's great. If we can't, I think everyone should be quite reassured that we have a number of good therapies available. I showed you data for ezetimibe, that was in the Improve It study that we talked about, as well as the PCSK9 inhibitors. And for both of those, it seemed like if we lower the LDL even further, that we could sort of reduce the risk of another bad event. The final point I'll sort of make here before we just wrap up is there are a number of new additional therapies that are in development to lower LDL cholesterol. And you may hear about these, and whether it's bempedoic acid or inclisiran or other therapies that are in development. It's very exciting to see that new therapies to address cholesterol continue to be developed, because we recognize, again, the importance of LDL and cholesterol in heart disease and heart attacks, and that there are still, despite everyone's best efforts, too many patients that continue to have these bad events from happening. And so it's very nice to see that we have a number of options available to us. I showed you the data for statins and Zetia and PCSK9 inhibitors, but I also just want you to be aware of the fact that there are a number of other therapies that are in development that may also be available to us to further reduce risk. So with that, I think we'll move to the final slide. Just some final takeaways and some final thoughts from me, and then we'll open it up for some questions. So first, and I think you've heard this in probably all of the sessions that we've had as part of this series, that reducing LDL cholesterol with a statin medication is the cornerstone for managing your risk, for reducing your risk, and treating your cholesterol. Next, that it is important to start early to prevent heart disease. Remember, we talked about sort of that cumulative effect about how high is the cholesterol and for how many years. And so we really want to try and start early and get the LDL down. And it's critical to aggressively lower your LDL to prevent any further events if you've already had one. We sort of want to, our first goal, of course, is to prevent it. If you've already had an event and we couldn't sort of prevent it, we certainly want to avoid the second event from happening. Next, that I've showed you some of the research data for Zetia and PCSK9 inhibitors, that reducing your LDL even lower than 70 seems to give you additive protection to lower the risk even more. And then last, that the clinical guidelines, kind of the best recommendations from our scientific experts, recommend that additional cholesterol treatment is warranted in patients that have very high risk and that have an LDL above 70 despite statins and lifestyle modifications. So with that, I'm going to stop. I know we went through a lot of material there, and I want to turn it over to the audience. I hope you guys have some questions.
Thank you, Dr. Desai. That was very enlightening and lots of interesting information. And I do have a lot of questions already. I do just want to alert everyone listening that if you have a question, please type it into the chat box. We have a very large audience, and so hand raising is a little difficult to do with so many people. So if you could type it into, excuse me, into the chat box, we would be very happy to answer the questions. I'm just going to start, and the first question is Lavoza effective in lowering LDL?
Yeah, that's a great question. So Lavoza is a sort of omega-3 fatty acid, and there's been a lot of talk and a lot of interest in omega-3s over the years. So what we know is that Lavoza was actually tested in a clinical research study, and it didn't seem to give you any added benefit on top of a statin. And so I think that's important for the audience to know. The other thing that's sort of worth pointing out that you may have heard about another therapy called icosapent ethyl or Vascepa. And that was tested in a recent study called the REDUCE-IT study. And that actually showed that this sort of prescription strength fish oil, if you will, did lower your risk. And so if you have an LDL that's relatively at goal, so you sort of got your LDL down to 50 or 60, but if your triglycerides are still elevated, that might be a good option. And again, I would sort of suggest that if you think that you might fit into that category, that you sort of reach out to your physician or your doctor, your healthcare provider, and ask them, whether that might be an option for you.
Great. The next question is, what sort of drug is ezetimibe?
Oh, that's a great question. Sorry, I should have gone over that. So the way statins work is they reduce the synthesis, the production of cholesterol in the body, and that's obviously one way that you get your cholesterol levels. The way ezetimibe works, it actually works in the intestine, and so it prevents the absorption of cholesterol from your GI tract. So the food that you eat, as it sort of makes its way through the GI tract, if there's cholesterol in there, there are receptors that actually absorb that cholesterol from the GI tract and bring it into your body in case the body needs it. That's sort of another way that it can alter its cholesterol levels. And so Zetia actually prevents the absorption of cholesterol in the GI tract. So it works in a slightly different way than statins, and that's a very, very important sort of mechanistic difference, if you will, between how the medications work.
Excellent. So the next question is, and this is actually a question I was wondering myself, if plaque buildup starts when you're in your 20s, why do we wait until we're between 40 and 75 to start treating with statins? The science and biology says so, so why wait?
Yeah, that is a really, really important and profound question. So you're quite right that from everything we know, cholesterol buildup and plaque buildup in the different arteries does start in your sort of 20s and 30s. And so I think what we should be doing and what we have to get much, much more aggressive about is on the prevention side, right? Waiting till someone's in their 40s and 50s or maybe even early 60s to start talking to them about preventing heart disease and preventing heart attacks, you really sort of miss the boat in some ways. Now, it's never too late to start, and I would always encourage everyone to try and adjust your lifestyle, adjust your diet, start an exercise program to try and get heart healthy. But I think the question is an incredibly important one, that if we're serious about prevention and we want everyone to sort of have the best chance of never having heart trouble, then we've got to start earlier. And I think educational programs like many of the ones that Mended Hearts and NLA actually do are quite important on that side, where they are out in the community trying to educate people and really engage people around these concepts. And so I think your point is a very, very good one, that we should be starting early. It is about sort of your cumulative exposure to cholesterol that matters here, and there really is no substitute for starting early. Now, that's not to say that we want to put everyone on medications early in their life, but I think we want to inform people so that as you're talking about lifestyle and exercise and diet and other things, maybe even public policy programs, that we're talking about those early on in elementary schools and middle schools and high schools, and not waiting till someone's in their 40s to start talking about prevention. I think it's a really critical question.
Great, thank you. So what are the side effects associated with a PCSK9?
Yeah, very, very good question. So, the PCSK9 inhibitors, by virtue of the way that they work, they have to be administered as a subcutaneous injection. And so for individuals that have diabetes and administer insulin, or are quite familiar with that, and they're administered either every 2 weeks or every month thus far. There are others that are in development that are actually going to be administered potentially every 6 months. The side effects, or what we've seen thus far in all the research studies, are quite minimal. In terms of the things that we typically associate with statins, like muscle cramps or other symptoms like that, we have not seen those types of side effects with the PCSK9 inhibitors. And so, everything we've seen thus far is that they're incredibly effective and quite safe.
Great, excellent. Okay, so the next question is, what does high intensity statin mean?
Yeah, very good question. So we sort of talk about these definitions of kind of statin potency, if you will. And the most important one to kind of be aware of is this high intensity statin. And what that means is that you're using a statin that can pretty significantly lower your LDL. And the two that we typically think about for that are atorvastatin, or formerly known as Lipitor, and rosuvastatin, or known as Crestor. And the doses that we kind of typically think about for that are atorvastatin 40 milligrams or 80 milligrams, or rosuvastatin or Crestor 20 milligrams or 40 milligrams. So if you're taking one of those drugs at one of those doses, you can expect your LDL to go down by about 50%. And that's what's typically referred to as a high intensity statin regimen.
Great. Someone asked if you could say more about the new ultrasound that can identify potential blisters in the arterial walls.
Yeah, so there's a lot of interest, as I showed you kind of on that very, very first slide, right? That where all the action is with kind of lipid and cholesterol buildup is actually in the vessel wall. So you have to kind of figure out some way to get in there to see what's happening. And as of now, the way that we've typically done that is by having to put a catheter into the heart artery and do an ultrasound from inside the vessel wall. People are now developing other non-invasive, techniques, much like getting a CAT scan or an MRI, and maybe that those would also be sort of good enough, if you will, with the right kind of tracer and the right protocol to actually look at plaque and cholesterol buildup in the vessel walls. I don't think that that's still very much in the works. There's a lot of research kind of happening there, but I think the key point for our audience is to really go back to that first slide, about where does the lipid and cholesterol build up, that it really gets into the vessel wall, in the heart arteries, in the other arteries, and that's where all the trouble starts. And so, by lowering your LDL aggressively and early, you can really avoid that whole kind of cascade of things from happening, and ultimately prevent either the first bad event from happening or any subsequent events from happening as well.
Great. So I know we're coming up on the hour. We have 1 minute left, and there's so many more great questions, but I have, I'm not going to be able to get to them all. So I thought I would just ask two that I could. One is, what is that website for the risk tool equation? If you could do that one.
Yep. Sure. We can do that one quick. And I wonder if, maybe we could even send this around to the participants, or post this maybe with the video,
Yep.
if that's going to be available. But if you Google ACC risk calculator, it'll be the first link that comes up. It actually winds up being kind of a long URL, but I think that we should definitely send that out to the group and include that with with this information, so that everyone can kind of get on and play around with that website.
Yeah, absolutely. And the slides and a recording of the presentation will be available on the Mended Hearts website usually within 24 hours. Sometimes it takes us 2 days, but it will be available right from our home screen. You'll see the blue box that says Beyond the Numbers, and if you click that, it'll take you to all of the past recordings and any of the PDF of the presentations. And then you can register for this next in the series. So thank you, Dr. Desai, for spending an hour with us. We really appreciate it. Everyone else, if your questions were not answered, we will have the questions that we gather afterwards, and we will try to get them answered for you all. Some of the diet questions, if you tune in to our one on July 16th, it's the 5th in the series. We will be talking about diet and nutrition for the entire hour. But the next session in the series is understanding and interpreting your cholesterol blood test, which will be great to know since now we can access our blood results usually online. And so we'll be able to understand what all of those numbers mean. That is on June 23rd at 5 p.m. Eastern Time. And I just wanted to, again, thank everybody for joining us. And Dr. Desai, thank you for spending the hour with us. Everyone, have a great day.
Thanks, Andrea. Thanks, everyone. All best to you.